Good evening, everyone, and welcome to the CESPHN Annual Immunisation Update. My name's Kira Wright. I'm the Immunisation Team Leader here at Central and Eastern Sydney PHN. Also with us from CESPHN tonight are Immunisation Program Officers Mimi Campbell and Kaylin Khaleesi-Rad. I would like to introduce our speakers for this evening, Martina Gleeson, Tran Nguyen, and Vicky Shepherd. Thank you for joining us. But first, I'd like to acknowledge the traditional custodians and sovereign people of the land across which we work. I recognise their continuing connection to land, water and community and pay respect to elders past, present and emerging. I'd also like to extend that respect to all Aboriginal colleagues joining us tonight. A note on housekeeping, this webinar will be recorded and available on the CESPHN YouTube channel within the next couple of days. At the end of the webinar, an evaluation survey will pop up in your web browser. We appreciate your feedback, so please complete this to allow us to issue certificates of attendance. Please ensure that you submit your questions via the Q&A function throughout the presentation. To view this box, hover over the toolbar at the bottom of your screen. A few upcoming events that the PHN are putting on here. We also have cultural awareness training. There's some upcoming workshop dates there for you. This event is RACGP approved for 1.5 hours education and 1 hour reviewing performance. My Medicare information. The Head Health phone line is another useful tool. And the newly renamed Medicare Mental Health Centres. So they were previously the Head to Health Centres. No GP appointment or GP referral is required. Additionally, we have DFSV Assist, and we can provide training and consultations and referral support. We also have a mental health services directory. You can access it via that website there. And there's also training on IAR level of care. So first up tonight, we have a short presentation from Martina on health pathways. Martina, welcome. You're on mute, Martina.
You must have muted me. Thanks, Kira. Thanks for inviting me. If you could go to the next slide. So just a reminder that you have two health pathways teams. These are the QR codes. We've now going to our personal accounts, and the universal login that we've been using for the last 5 years is going to be phased out on the 31st of March. There are some benefits in having a personalised login, and the process is very easy. So it's worth actually in the next week planning to log on to Health Pathways and create your personalised login and save your username and password so that you can get the extra benefits from now and definitely from the 1st of April. Next slide, please. So the benefits of personal accounts are that you've got better security, and you can reset your password if you've got any concerns. And we've also got a couple of new features, one is the AI enhanced smart search, so that you can search for a very specific thing, like, for example, antibiotics in community acquired pneumonia. And the smart search will take you to that part of the relevant health pathway so that you can find the information you're looking for quickly. And there's also the capacity to do some tracking of your own CPD, and you'll be able to use health pathways to create a report of all of the health pathways you've used over a period of time and the hours you've spent there, and you can put a little reflection on them if you want to, and then it will generate a report that you can upload to your CPD home as proof of the work that you've done just in the process of providing care to your patients. So no particular extra effort required. So that's really helpful. Your personal data and usage data is secure. We don't share it. We share aggregated and anonymized usage to help us improve quality and monitor usage, but we don't use your personal data. So yes, just another thing to encourage you to register and create a personal account in the next couple of weeks. Next slide, please. If you're deciding which pathways to use, it's particularly important if your patient is accessing services in a particular LHD. So use the Southeastern Sydney ones when they're accessing a service in the Southeastern Sydney LHD, and the Sydney ones when they're accessing services in Sydney. Next slide, please. Here is a list of pathways on the Southeastern Sydney site that are available. And it's worth letting your practice nurses know that these ones exist, because often they're the ones who run the immunisation program in your practice, and especially the cold chain, vaccine storage and cold chain, all of the updates of the immunisations and how to manage an adverse effect from an immunisation. I think that's the last slide, Kira. There you go. Contact details for members of the Health Pathways team if you're having any issues. In particular, if you're having any issues with creating your personalised login. And don't forget about the send feedback button. So if you find a broken link or an error and you'd like to feed that back to the team, please click on that send feedback button and let us know so that we can ensure our Health Pathways are meeting your needs. End of story. Thank you.
Great. Thank you so much, Martina, for joining us, and great reminder to create your personal login for Health Pathways.
Thank you.
Thanks, Martina. Next up, we have Dr. Tran Nguyen, Staff Specialist and Pediatric Infectious Diseases Specialist at NCIRS. Tran is a Senior Medical Officer in the Research to Inform Policy team at NCIRS. She also works as a General Paediatrician and Pediatric Infectious Diseases Physician at Bankstown Hospital and in private practice. Tran is an adjunct lecturer at the Sydney Children's Hospital, UNSW Faculty of Medicine and Health, and has extensive experience working in the New South Wales Specialist Immunisation Clinic. Welcome, Tran.
Thanks so much, Kira. I'll just try and share my screen now. Okay, let me know if you can see that okay. Is that working okay?
Nothing yet.
Oh, sorry. Okay, try again.
Yeah, we can see that now. Thank you.
Great. All right. Thank you so much for having me and for everyone else to join this evening. I would like to thank many of my colleagues at NCRS for their contribution in this presentation as well. Sorry, it's not moving for some reason. Okay, here we go. So first, I'd like to begin by acknowledging the traditional owners and custodians of the land on which I live and work. And for me, that's the Gadigal people of the Eora Nation. And I'd like to pay my respects to elders past, present and emerging, and extend that respect to any Aboriginal people present here with us today. I have quite a lot to cover in the next hour or so. So this is an overview of what we'll touch on. First, we'll talk about the 2025 vaccine recommendations for COVID-19, influenza and RSV. And second, we'll talk about vaccination in the special risk groups, particularly in the pregnant people, and some changes to the Australian Immunisation Register, and also vaccinating immunocompromised people. And third, I'll try to give some practical tips for vaccine delivery, particularly in sick children and in people with additional needs. And lastly, we'll talk about some strategies to promote those recommended but unfunded vaccines. So first off, COVID-19. This is just a little bit of data just to remind us all that COVID is definitely still around. And so this is notification in New South Wales in the last year and a half up to the 1st of March 2025. If you look on the graph on that left side on the top, COVID-19, COVID activity, it still remains somewhat similar throughout the year with some peaks in June or July last year. And certainly in the last couple of months, we've seen a little bit of increase in trend towards the end of December and early January this year, and then kind of decreasing a little bit towards February and March. But in the past week alone, we have seen a 9% increase in COVID notification. And this is to note that the RAT tests are actually no longer notifiable in most jurisdictions since 2023. So this number is, likely underrepresented of the actual case numbers. And then when we look across down the graph, influenza and RSV, you can see there with the other two viruses showing quite clear seasonal trend, more in the winter. And again, the recent data in the last week shows that there's been an increase of 9 to 10% notification as well as we're heading towards the colder weather in New South Wales. Looking at the different COVID variants in our community, currently in Australia and in New South Wales, all current infections are caused by the JN1 sublineages. And when you look at this beautiful sort of pictures, multicolored graph, in the recent months, the predominant circulating variant is the XEC variant, represented in that maroon color. And in the last 3 months alone, we've seen sort of a new variant emerging, which is the LP.8.1 variant. But all of these variants are still sub-sublineages of the JN1 variant. So poll 1, please, Kira, if you can start that for everybody. Yep. So if you can look at your screen there, just want to have, if you want to take a guess, what is the approximate proportion of adults aged 75 years and over who have received a COVID vaccine in the last 6 months, which is the recommended schedule in Australia at the moment? Whether is it 15%, 30%, or 70%? Can we see the result, Kira? Or oh, there we go. Excellent. So I think a lot of people are right in saying essentially the coverage is low for the recommended age group. Let's go to the next page on coverage. So when we look at COVID-19 vaccine coverage, the highest risk group is the adults 75 years and above who are recommended a dose every 6 months. The actual data shows that only 16.4% of those actually receive a dose in the last 6 months. Looking at the next age group of recommendation, adults 65 to 74 years age group, only 24.8% of those receive a vaccine as per recommended schedule. And then when you look at just adults from 18 to 64 years age group, less than 5% receive a COVID vaccine in the last 12 months. And perhaps most of these 5% are the people with severe immunocompromise. So essentially what this show us is that COVID vaccine coverage is low. So what are the key points for the 2024-2025 COVID vaccine recommendations? Just a little caveat here is that as of today, unfortunately, the 2025 COVID statement is not yet released by the department. However, I can share that the recommendation for this year will not change substantially compared to what we already had last year. So essentially the key points to remember here is that age remains the single most important risk factor for severe COVID-19. And so the highest risk group is adults aged 75 years and above, including aged care residents. COVID-19 vaccines are still recommended every 6 to 12 months for all adults from 65 years and above, aged care residents, and adults with severe immunocompromise. From November of 2024, we've had a newly approved COVID vaccine that contains the JN1 variant. And so at the moment, the COVID vaccine available for use are the Comirnaty JN1 containing vaccine or XBB.1.5 containing vaccine. There is no recommended preferential use for either of these vaccines, as long as you use the right vaccine for the right age. And COVID vaccine remain funded for all eligible individuals, including those without Medicare. So looking more closely to the actual, the current recommendation, as I said, the 2025 statement is yet to be released, but it will not change substantially from this. Looking at the primary cause, so healthy children, anyone below 18 years of age, are not recommended to receive COVID-19 vaccine because they're deemed very low risk. Healthy adults who are 18 years and above are recommended to have 1 primary dose, and unless they have other medical risk conditions or immunocompromised, then they might require more than 1 primary dose. When we look at the booster dosing advice, an easy way to remember this is, again, high-risk individuals, which are the adults 75 years and above. They are recommended a dose every 6 months. The next group down is the moderate risk individuals, which include adults aged 65 to 74 years, or adults aged 18 years and above with severe immunocompromise. They are recommended 1 dose every 12 months. When you look at that table, you might recall this purple table in the ATAGI statement. And it does have a caveat of saying that you can consider a dose every 6 months or every 12 months for certain individuals. And that is to say that those people are eligible for a dose every 6 months, and that dose is most likely to benefit aged care residents and those with medical risk conditions. Just a couple of frequently asked questions that we've seen for COVID-19 vaccine. Can we co-administer? Yes, definitely. You can give it with other vaccine, including flu, pneumococcal vaccine, RSV vaccine, preferably to be given in different limbs. However, you can give it in the same limb as well, with a little distance, about 2.5 centimeter apart. NCRS has a really nice guideline for this, if you would like to refer to that when you need it. And the next question is about pregnant women. I will go through some advice for pregnant women in the later section. So I won't go too much into this at the moment, but essentially the thing to remember is that COVID vaccine booster are not recommended for previously vaccinated healthy women. That is, that they have received a primary dose of COVID vaccine. And then what about timing of vaccination following a previous COVID-19 vaccination? There is no recommended minimum interval for a COVID vaccine following infection. So next off, influenza. Again, looking at the landscape of influenza in 2024 compared to previous years, you can see in this graph here, this is influenza cases in Australia in the last 5 years. However, taking out the years 2020 and 21 because of obviously the COVID pandemic and the public health restrictions. And so when we look at that, the year 2024 is in green dotted line, and it was a huge year, a season of over 160,000 cases reported in New South Wales alone, and that is well above the overall average of about 50,000 cases per year in the previous decade. And when we look at this notification rates by age in New South Wales, so this is per 100,000 population, we can see that children in particular are disproportionately affected by influenza. So in this graph here, in winter last year, the group with the highest rate of notification is children from 3 to 4 years age group, followed by children from 1 to 2 years age group. And essentially all children up to 16 years of age are your highest notification rates. And that statistic is alarming, because when we then look at vaccination coverage data, particularly in children, we have currently very low vaccination coverage for influenza vaccine, especially in children under 5. And this is the group that is, eligible for a free influenza vaccine and is recommended. So when we look at the data for all people in New South Wales, we are below national average across all age group for vaccination coverage. And in children under 5, that percentage is only 24.5%. And even in our elderly population above 65 years of age, only 58.4% coverage. And then when we look at the Aboriginal and Torres Strait Islander people, and again, this is the group that has NIP funded vaccine for all from 6 months and above, the children are disproportionately having low vaccination coverage of only 17.5% of those under 5 years are actually vaccinated. And again, well below national average. So the take-home message for influenza vaccine key points this year is that there are no changes to the eligibility cohorts compared to last year. So the recommendations is the same. It is recommended for all above six months or above. And for those who are 6 months old to 64 years of age, a standard age appropriate influenza vaccine is recommended, where for older adults, 65 years and over, an adjuvanted vaccine is recommended. Now this year, as I think you might have followed the news about the avian influenza vaccine, influenza outbreak. Just a note to say that the seasonal influenza vaccine is not protective against avian influenza virus. However, it is still recommended for people in occupational risk groups because there is a risk of viral reassortment in the case of co-infections of these two different influenza viruses. The main change for this year, though, is the WHO has removed one of the influenza strain, the B Yamagata strain, out of the formulation. So we are transitioning from quadrivalent influenza vaccine to trivalent formulation. However, because of manufacturing transition for 2025, we are still using the quadrivalent vaccine under the NIP as well as in the private markets. And you will see that transition to trivalent in the years to come. So here is the actual recommendation. You can see in the box on the left side, the group that are recommended and funded are essentially all children aged 6 months to 5 years, to under 5 years, all adults aged 65 years and above, all Aboriginal and Torres Strait Islander people aged 6 months and above, any pregnant woman in any stage of pregnancy and in each pregnancy, and people with medical risk conditions. And so healthy children and adults aged 5 to 65 years of age without uneligible medical risk conditions are not funded for a vaccine, but they are still recommended. This table is in the current 2025 influenza statement, and it shows you all the vaccines that are available for use in Australia this year by age group. I just want to point out that the current statement that you see released just over a week ago has a little just a little error in that flu quadri was not listed as NIP funded. So the tick in the white box are the NIP funded vaccine. And in the current statement that you can see online now, flu quadri did not have the white box there, but the department will be publishing an updated version of that to include flu quadri as an NIP funded vaccine for the children under 5 years of age this year. Timing of influenza vaccination, we get this question a lot at NCS. Essentially, ideally, to be given before onset of each influenza season, as you already know, and when the vaccine becomes available, which is usually end of March, early April in Australia. People can have it before international travel, and obviously the highest level of protection usually occurs in the first 3 to 4 months after vaccination, but is expected to last all year. And vaccination should continue to be offered as long as influenza viruses are circulating. And as we can see last year, that the season lasted for quite a long time. So if, for people who coming to say August, September towards the end of winter who haven't had influenza vaccine, and while the viruses are still circulating, I would still be recommending the vaccination. And again, to emphasize that co-administration is okay. A couple of frequently asked questions again, for travelers, do they need a second dose, especially if they're traveling to the Northern Hemisphere in the later half of the year? The answer is yes, they may receive a second dose before their travel. Second question, can flu vaccine be co-administered? Yes, co-administration is absolutely fine. When you look at the guidelines, it does say may be considered separating fluid quad with Shingrix, but that's one particular case. However, if there's no time to separate the vaccine, you can also give those two vaccines together. Is flu vaccine safe for people with egg allergy? Yes, absolutely. It's very low risk. And is a flu vaccine recommended if someone already had the flu? And the answer is yes, because it will decrease the risk of infection of other flu strain. Next, RSV. Sorry, I'm going a bit fast because there's a lot to cover. So RSV, again, looking at the overall RSV notification per 100,000 population. As we're coming into winter, RSV season certainly start around March to April every year, as you can see here from last year. So around March to August, September every year. And again, RSV disproportionately affects young children, particularly children under the age of 1, as you can see from this graph here. So what RSV prevention strategies do we have? There are 2 prevention strategies that we have. One is vaccination, and that is for pregnant women or older adults, comes in a form of a Brisvo or a Rexv for the older adults. For infants, we have a monoclonal antibody, which is not a vaccine, but it is essentially passive immunization by giving the infant a long-acting immunoglobulin, and that is nirsevimab. Sorry. Oh, yeah. So this is the eligibility criteria for the RSV immunization product for this year. For pregnant women, any pregnant woman from 28 weeks of gestation is eligible for a dose of RSV vaccine, and that is Abrysvo and Abrysvo only. For children, infants and children who are eligible for nirsevimab, which is the monoclonal antibody, if they're under 8 months of age and not protected by maternal vaccine, that means they have not received any vaccination or the mother have not been vaccinated for more than 2 weeks before delivery, or the mother has a severe immunosuppressive condition, or the infant has had some kind of treatment such as exchange transfusion or ECMO that lead to the loss of maternal antibodies following the RSV vaccination during pregnancy, those infants are eligible for nirsevimab. Or the under 8 months old infant that has a risk conditions that listed in the Australian Immunisation Handbook. So those infants, regardless of maternal vaccination, is eligible for a dose of nirsevimab. For the older infants from 8 months to 24 months of age, if they have a medical risk conditions, regardless of maternal vaccination, or if they receive monoclonal nirsevimab in the first season, they can receive a second dose. For adults, for older adults, they are eligible for a dose of RSV vaccine, Abrysvo or Arexvy, if they're above 75 years of age, if they're Aboriginal or Torres Strait Islander, aged 60 years and over, or if they are 60 to 74 years of age and has a medical risk conditions. So in terms of NIP funding or funding for RSV products, you can see in this table here, Abrysvo is the only vaccine that is on the NIP for pregnant women. The Beyfortus, which is the antibody for infants, is funded under the state and territory programs, which you can check for the individual state. Unfortunately, for the older adults RSV vaccine, Abrysvo or Arexvy are not yet funded, even though they are recommended. So here's a little link to the state and territory nirsevimab program if you wanted to refer to it for further details. And this next section is really to say that, we understand that the rollout of 3 different RSV immunization products can be very confusing. And certainly, administration errors, even though rare, can happen. And there are reports, in the US as well as in Australia of some administration errors already happening. And certainly the most common mistake that we hear of or know about is that the adult RSV vaccine are given to baby by mistake. And so just a couple of useful ways for us to remember which immunization products. So as I listed here, Abrysvo sounds like embryo. I sometimes try to picture a picture of a pregnant woman, with the B in Abrysvo, and also to remind us that the Abrysvo vaccine, it is a vaccine and it needs reconstitution before you inject to the patient. Where Beyfortus, which is not a vaccine, it is a monoclonal antibody. The way I kind of try to remember it is that B for protecting the baby or B for Beyfortus. And one way to know in practice is that this comes as a pre-filled syringe. And so you're not doing any reconstitution before injection. And also that at the moment in New South Wales, you need to order it for the individual patient. So you will not be giving it to the patient in the same visit. So, so if you have a baby that presents for Beyfortus and that you're taking it straight out from the fridge to give it the baby in the same visit, it's most likely the wrong product. And then lastly, for Arexvy, just thinking about XYV being at the end of the alphabet, it equals older adults, 60 years and above. And again, this is a vaccine that needs reconstitution before injection. And hopefully it's helpful. Okay, so poll number 2, please, Kira, if you don't mind. Thank you. So just to jog our memory again, the question is who is eligible to receive Abrysvo free on the NIP? Hopefully we'll see the result. Excellent. Yeah, I'm glad, most people got it correct, but as I said, it is very confusing because, there are 3 different RSV products to remember at the moment. So I hope we can find our own ways to remember this and avoid the confusion. Okay, so a couple of frequently asked questions from our current experience. So for Abrysvo, we get asked a lot, when is the best time to give the RSV vaccine? And the answer is anytime from 28 weeks of gestation and any time of the year, regardless of the expected date of delivery. You don't have to time it so that it's given, soon before RSV season, etc. And this is also to say that, if you look at the NIP funding for Abrysvo, it does say 28 to 36 weeks of gestation. However, if you do give it after 36 weeks of gestation, it is actually still funded. So it is absolutely fine to give it after 36 weeks of gestation. However, you just need to remember if delivery occurs within 2 weeks, then the infant may need additional nirsevimab for additional protection. The next question is, what should be done if you were to give Arexvy instead of Abrysvo to a pregnant woman? And the answer to that is no repeat dose of Abrysvo is required. The woman will probably still mount an immune response enough to pass on the antibodies. And however, if after counseling to the individual patient and that the parents still, really insist on the infant having nirsevimab, and in that case, nirsevimab can be offered on a case-by-case basis. But as a general rule, if you did give Arexvy instead of Abrysvo, you don't need to repeat the dose of Abrysvo. Question number 3, what should be done in the case of inadvertent administration of Abrysvo before 28 weeks of gestation? So Abrysvo is TGA registered from 24 weeks of gestation. And so if you do happen to give it, say at 26 weeks of gestation, there is no need to give another dose. The safety and efficacy data from 24 weeks to 28 weeks of gestation are still being monitored. But at the moment, there is really no significant safety signal if you were to give between 24 to 28 weeks of gestation. Next question, what should be done if a pregnant woman is not vaccinated before 36 weeks of gestation? So as I touched on before, if we haven't given it by 36 weeks and delivery, is expected to be more than 2 weeks away, then you can give the vaccine as soon as possible and it will be funded. But if delivery occurs within 2 weeks, then the infant is recommended to receive nirsevimab when they're born. Can the vaccine be co-administered? Yes. Co-administration is fine. And that includes giving the flu vaccine, the Boostrix, or the COVID vaccine if required during pregnancy. And there's some people might question about close family members as well to receive RSV vaccine to protect the newborn, a little bit like the cocooning strategy that we do with Boostrix. And the answer to that is currently RSV vaccines are not registered for anyone under the age of 60, except for pregnant women. Sorry. And so next FAQs is about nirsevimab for infants. Again, what is the best time to give RSV? I'm sorry, this is a typo. It is not a vaccine. This should be a monoclonal antibody. So the best time to give nirsevimab is shortly after birth for infants who are born just before or during the RSV season, or shortly before the start of their first RSV season. And for infants who are a little bit older, 8 months to 24 months of age, then it should be given before the second RSV season, which is around March to April, if those infants have risk conditions eligible for nirsevimab. How long is the duration of protection? Nirsevimab offers protection for at least 5 months, but there is some early data to show that the protection may remain for 6 to 12 months. Next question is, what is the minimum interval between first and second dose of nirsevimab? The minimum interval is 6 months. And we would, again, ask that you consider the ideal timing for administration. And what about the infants who have had previous RSV disease? They are still recommended to receive nirsevimab once they're recovered. And the reason for this is that the protection from natural infection of RSV is not long lasting, and reinfection of RSV in infants is common. Also, just to note, these FAQs you can also find in the NCIRS FAQ sections as well. And lastly, for older adults, when is the best time to give RSV vaccine? The exact timing is less important for this age group, but you can time it with the pre-RSV season. And the reason for that is that protection for the older adults actually lasts multiple seasons. So yeah, that's the reason why exact timing is not particularly important. And certainly you should continue to offer RSV vaccine to the older age group throughout RSV season if they're eligible for it. Do they need booster doses? At the moment, there's not enough data for us to recommend any booster doses, and we do know that protection lasts for at least 2 years. And again, co-administration is absolutely fine. This is a link to the NCRS clinical guidance on RSV immunization product administration errors. It outlines different type of errors and what actions to take after that, and I think it'll be quite useful for you to have at hand. This is a table that I've summarized all of those recommendations for the 3 viruses, just for your reference. I won't go through them again, but you might find it helpful to kind of be put into one single table. Okay, so this is the risk conditions. We understand that when you look at the immunization handbook, different chapter have a different risk condition table, and that can be confusing for providers, in your clinic. So what we did this year is to align these risk conditions across the 3 viruses and have them all in one big table like this. And certainly to make sure that the risk conditions, if you see them appear in one, it will look quite similar in the other 2. The box that's colored in gray are the risk conditions that are not yet aligned across the 3 conditions. And the reason for those is just that some of these are specific to the particular virus. And we obviously can't generalize for all 3. Okay, so moving on to the next section, talking about special risk group, pregnant women. This is a really nice infographic that NCRS just created recently and is on our website. It shows you just a summary of what vaccines is recommended and when to give during pregnancy. And you can see here the 3 vaccines that are recommended are influenza vaccine, pertussis, which is Boostrix or Adacel, and the RSV vaccine, which is Abrysvo. The recommended time frame is written here as well. And again, I just want to emphasize with Abrysvo, even though it's recommended at 28 to 36 weeks of gestation, you can give it after 36 weeks. And it's still funded for the woman. And really, we really want to emphasize that gestational age shouldn't be a barrier to vaccination. If someone turns up, with a slightly unclear gestational age, for example, they're about 27 or 28 weeks of gestation, really the key is to still offer the vaccination and encourage them to take up the vaccination. And lastly, for COVID vaccine and pregnancy, as I mentioned before, if the pregnant woman has received a primary dose of COVID vaccine and they're healthy with no medical risk conditions, then a booster COVID vaccine is not recommended during pregnancy. So, pregnancy itself is not considered a risk factor for COVID-19 unless the pregnant woman has other medical conditions, etc., that put them at risk. And in those cases, then you would discuss having COVID vaccine during pregnancy. So a couple of changes to the Australian Immunisation Register this year. The minor changes include with COVID-19 vaccine, you will see that the manufacturer names will no longer be displayed. For example, the old Pfizer Comirnaty XBB will be displayed as just Comirnaty XBB vaccine. However, the AIR vaccine codes for COVID-19 vaccines will remain the same. You might see changes in the vaccine type field as well, where the state program, the private type have been removed and replaced with just other. So this is how it looks on the AIR. And the most important thing this year is that there is an introduction of the antenatal indicator, as you can see here on the AIR website. So if you go through the PRODA, that's the antenatal indicator you will see, as well as the change in vaccine type. For practice with older software, you might find that the antenatal indicator is included under the vaccine type, but all of that should be changed by around October this year. where you can see a clear internatal indicator in the air. Now, for people who are immunocompromised, this is a huge topic, and it's really, impossible to summarize in a couple of slides. And the reason for this is that people who are immunocompromised due to disease or treatment, and that includes the infants and mothers who receive immunosuppressive therapy during pregnancy. For those people, the level of immunocompromise vary quite significantly depending on what the disease is, what the treatments are. And in general, the general rules of immunocompromised people is that live vaccine may be contraindicated because of the risk of adverse events or vaccine-related disease, and they may require extra primary doses to optimize their protection. However, to know, which individual or which disease to avoid, which vaccine, you really need to refer to the Australian Immunisation Handbook and probably discuss with a treating specialist as well, if required. We have this year created a more comprehensive guide for immunocompromised for vaccination in immunocompromised people, or what we call the immunocompromised chapter. And that chapter is a completely brand new chapter that will be released in the Australian Immunisation Handbook at some point this year. So you might, just look out for that in the next couple of months. And hopefully you see a new chapter that is better laid out and clearer to help with your practice. Vaccine delivery for sick children and people with additional needs. What are the practical tips? So for sick children, essentially, if they are acutely unwell with a minor illness, and that is having no acute systemic symptoms or signs, then we would say proceed with vaccination. If they do have a fever that's above 38.5 or an acute systemic illness, then the advice is to defer all vaccines until they're not febrile. You can refer to the Australian Immunisation Handbook. There is a table in there, a resource table, that is a part of the pre-vaccination screening checklist, and it does have instructions and guidance as to what to do in various circumstances, especially with relation to sick children. And for children who have not an acute illness, but rather a severe or chronic illness, then again, I would suggest that you refer to the AIH vaccination for special risk groups, which is a new chapter that is going to be released in the next couple of months. For people with additional needs, which include, people with needle phobia or people with behavioral disorders, we do also have a guidance on NCI's website. But essentially, the first thing to think about is the clinical considerations. So we need to identify, are they eligible for the vaccine? We need to understand who can provide, a valid consent, an informed consent, and then before the procedure, usually we would then discuss with the parents or the caregiver, any supportive holding techniques, any positioning for vaccination. And these are a couple of suggested vaccination positioning that is in the AIH that you can find it there as well for children at different ages. So children under 12 months might be positioned in a cuddle position. For an older child, you might want to try a different cuddle position, as you can see in the picture here, with the adult holding the arm. And then for an older child, again, you can try a straddle position. So those are the pictures that you can show to families and discuss before vaccination happen. And then after that, we might then consider some practice adjustments and consideration. And those consideration may be that you arrange an appointment time where the practice is less busy. You might allow extra family or carer support for the person. You might arrange for the person to be seen by a familiar doctor or nurse, and certainly enable 2 vaccinators in a room. Extra pair of hands is always helpful. You might want to have a dedicated private consultation room, and also to minimize waiting time so that when the patient arrives at the practice, you could then direct them directly into the room. And certainly, preparing vaccine out of sight and providing distraction tools. So these are just a couple of examples that we use a lot in children, particularly, because I'm a pediatrician, these are the things that I use quite frequently in my practice. So the top picture you can see here, that's the buzzy bee. So often, provide a bit of vibration, a bit of distraction for the child. And then, the lower picture here, I have to say, this is something we don't have in my practice, but we certainly use a lot of iPads and, digital distractions. But this is kind of a virtual reality type of digital distraction for children who are really needle phobic. And then for younger babies, of course, bubbles and toys. But I think, a lot of us are very good at distracting babies, but it's more the older children and adolescent that it's quite a challenge. And then lastly, if we've tried all of those, measures and vaccination is still not successful, then I guess, a tip is to review what worked and what didn't. We might consider adjustments again. We might make a follow-up appointment. Or lastly, you might want to consider referring to a specialist immunisation service. There are services in Sydney, there are services at Westmead or Randwick. At Westmead, the clinic is called the New South Wales Immunisation Specialist Service, or NSWIS, and you can certainly refer to that service. At Sydney Children's Hospital in Randwick, that's called the Specialist Immunisation Clinic, where I've worked before. And in John Hunter as well, there is now a specialist clinic to assist with vaccination of people with additional needs. So lastly, I'll just talk about the strategies to promote those recommended but not funded vaccine and immunization products. This is called a tree of strategies to improve vaccination uptake. And this is a project that NCRS was involved with many different immunization partners in New South Wales, and many of you might already be aware of. And you can see the tree really show us the complexity of developing vaccination strategies to increase uptake. And of the foliage here that you can see are essentially the practical tips as to what we do to improve our services, improve our communication, and improve uptake. And then those little white bubbles here are the fruits of the tree that bears the result of our strategies, which means things like data reminders to help parents remember, improving services, improving connection to communities. And the trees and roots here just shows the complexity of the social, cultural factors and the policy investments to try and help these strategy be successful. So I take some of those points into these little boxes for us to remember. So some of those strategies include improving access and certainly providing extra support for those most vulnerable. Offering opportunistic vaccines is really important. People might present to you for, I don't know, a broken arm or, a needle stick injury, and then you can use that opportunity to offer the flu vaccine, for example. And certainly knowing that co-administration is okay. That means, say if there was a child to present with a needle stick injury and they require tetanus vaccine, I might also offer the flu vaccine because it's okay to co-administer. The second box here talk about active recommendation. This is the single most important strategy to promote vaccine uptake. Active recommendation by a healthcare provider is shown by many studies that is critical to encourage vaccine uptake. We also shouldn't assume that people can't afford a vaccine because it's not funded. And certainly we always promote supportive and two-way communication. And the third box here, vaccine safety and effectiveness, essentially to say that, we need to assure our patient that the vaccine that are recommended are safe and are effective. And the resources for us to know that and to assure our patient is that, you can certainly refer to many of the, AIH, the handbook guidelines. You can refer to NCRS clinical guidance as well as the OSVAC safety. If the patient has, a particular safety concern that you need to address, sometimes, you can find that safety data under the OSVAC safety monitoring on NC's website. And that might be helpful to present that data to the patient. The next box here is about communication and information. Using display information, posters, resources to encourage, giving information to the patient. Use visual aids where possible. We always try to use jargon-free, simple messages, and certainly countering misinformation is important when you're trying to promote a recommended vaccine. And lastly, and I know many practices might have already done this, is to have to collect data from your practice to know what is the gap in your service and what's the community needs, and also to have reminders that are timely and personalized. So essentially, these are my take-home messages. There are no changes to COVID-19 or influenza vaccine recommendation this year. With the RSV immunization products, yes, there are 3 different products, and yes, they are confusing. So we need to ensure the right product is given to the right person at the right age. And to remember that for pregnant women, a Brisvo is the only vaccine to use for pregnant women. For infants, the Nirsevimab, which is not a vaccine, is a monoclonal antibody. That's the only product to be used. And in older adults, Arexvy or Brisvo can be used. And finally, for vaccine uptake, active recommendation is so critical to encourage uptake, and I hope that we can all get the ball going from here. I think I've just got the next few slides of further resources from NCs if anyone wants to scan these for access. And here's the OSVAC vaccine safety data as well. And if you subscribe to our newsletter, the weekly jab, you can keep up to date with these vaccine news and information. Yeah, and I think that's it. I'm happy to take any questions.
Thanks so much, Tran. That was amazing. You covered a lot of ground and lots of practical tips in there too. So thank you very much for that presentation. There are a few questions already, and I encourage everyone online to put in any other questions they might have. The first one is, if mum wants to split up her DTPA, flu and RSV, what is the recommended spacing of the vaccines? And I guess I'll add personally to that as well that, what can we say to the pregnant woman to try and encourage her to have them all at once?
Yeah, I think I'm not aware of any particular minimum interval between those vaccines because they are okay for co-administration. So certainly, I would time it as the timing that suits the pregnant woman for their multiple visits, because, during antenatal care already the pregnant women have a lot of visits, and the less appointments, the better for vaccine uptake. So I wouldn't, book a separate appointment to give the vaccine if that's possible. And sorry, what was the second part of your question?
I guess, how can we reassure the pregnant woman that it's totally fine to have the vaccines all at once, and it's probably, better, for her personally as well?
I think we'll have to go back to our data. I mean, it depends on the patient and how much information they require. If, you could print out fact sheets that are available on the NCS website or New South Wales Health, you can print out guidance to tell them that it's absolutely safe and effective. Because we're talking about so many different vaccines, I'm not sure if I can kind of give a one number. This is the vaccine effectiveness for all 3. But certainly you can show them the immunization handbook guidelines, the recommendations, and show them that, it's, there are sections in there that's really written very clearly that co-administration is okay. And there are numbers that you can quote for vaccine effectiveness as well, if that's what, the woman wants to know. In terms of vaccine safety as well, each of these vaccine under the Australian Immunisation Handbook has a safety section that outlines any significant concern. And certainly, I'm not sure if Vicky is aware of any New South Wales Health document that might have a combined. Yeah, because for me, in my practice, I would go to the individual chapter and kind of just show them the individual data in there.
Great, thanks, Tran. Another question, do the specialist immunisation services at the locations that you listed also see adults with special immunisation needs?
Yeah, unfortunately, they are for children's only. I don't know of the adult services that also would do those sort of work, but I know what my colleagues do sometimes for adults with, say, intellectual disability, for example, is to time them with a procedure. So often we see dental procedure or any procedure that they require GA, they are great opportunity for opportunistic vaccinations. And that's certainly what I do for, my patients who are like 16 to 18 years of age, where they're really kind of almost an adult. We often try and time it with a procedure that they're going to have. And certainly, when I see a lot of children with intellectual disability, as a general pediatrician, it's common that I will have to you know, align all their blood tests, their vaccinations, and their dental checkups sort of in that one big appointment at one time. And often those are done in a hospital. So
That was just that way. Yeah. Thanks, Tran. A quick answer, as we've already discussed in our webinar, there is 75 to 79-year-olds entitled to free RSV vaccination.
Sorry, 75 to 79. Yeah, so none of the RSV vaccine is funded for the older adults at the moment, even though they're recommended. So unfortunately, they are still, just privately purchased.
Yeah, thank you. And a question that apparently some doctor, it's an anonymous person, so I'm not sure, has immunocompromised patients that are under 60 years of age, where their specialist or immunologist has recommended either Brisbane or Arexvy for them. How do we go about this?
So currently the Abrysvo is only registered for people from 60 years and above. So you definitely can't give it for anyone under 60. Arexvy, I'll have to double check registration, but certainly we are
60
also,
as well.
yeah.
Yeah.
So because of that, you can't give it to anyone under 60 unless they're pregnant.
Yeah, thank you. I think that's it. I'll thank you, Lauren. Lauren has added in a good resource regarding giving pregnant women vaccinations. So there's another resource within the chat to have a look at. Vicky?
I was just going to say for immunocompromised people under 60, I mean, it can be given off-label, and recently I understand the TGA is considering a lower age registration. So while it still wouldn't be funded for people at younger age, that registration is probably coming through quite soon.
Great, thanks for that, Vicky. One last question. In February, it was advised to exclude babies who had a laboratory confirmed RSV infection for Beyfortus. Has this been removed from the eligibility criteria?
So are these healthy babies or baby at risk? Because if they are babies under 8 months of age, and if they fit the eligibility criteria, which means they're not protected by maternal vaccine or they have medical risk conditions, then they are still eligible for Beyfortus, even if they've had an RSV infection. Does that make sense? So, but if they're a healthy baby whose mum has had vaccine and has got no medical risk condition, then they're not eligible for Beyfortus.
Yeah.
Yeah.
Great.
So when you have RSV infection, that doesn't exclude from having Beyfortus, essentially.
Yeah. Excellent. Great. I think that's it for the questions. So thank you so much for your time, Tran. It was an excellent presentation. We covered a lot of ground, and I'm sure everyone's learnt a lot from that. Next up, I'd like to introduce Vicky Shepherd. Vicky is a public health physician who has been working in the New South Wales Health since 1999. Vicky's current role is Director of Southeastern Sydney Public Health Unit, and she's also a member of the TGA's Advisory Committee on Vaccines. Welcome, Vicky.
Great, thanks very much. Good evening, everyone, and thanks for your attendance and attention tonight. So yeah, I've been asked to speak about adolescent vaccines, and just as a note, I work in Southeastern Sydney Local Health District Public Health Unit, and this depicts, the map here depicts our region, which is home to the Darawal, Gadigal, Warragul, Guigal and Bidjigal peoples, and I pay my respects to them. So why are we going to talk about adolescent vaccination? Is that an issue for general practice and pharmacy? Well, of course, we do have the school program, which has been going for about 20 years now in New South Wales. It's a bit simpler now than it used to be. And I'll talk about that in a bit more detail in a second, but we're protecting young people from human papillomavirus, HPV, diphtheria, tetanus and pertussis, and meningococcal ACY. But as Tran alluded, adolescents are also important to think about for influenza. If they're Aboriginal adolescents, then it's funded. And if they're adolescents with significant medical conditions, that's also a funded vaccine. But it should be recommended for all adolescents. And, last year we meet weekly with Sydney Children's Hospital, and we saw a lot of really terrible complications of influenza. So it can affect healthy young people quite badly. And that's also being seen in the Northern Hemisphere this year. So it's a good vaccine to recommend to parents, even for children or adolescents who aren't eligible for a free vaccine. And then we'll talk a bit later. There's a bunch of funded catch-up vaccines for both from the childhood and adolescent schedules that we don't offer in the schools. So it's really important that in general practice and pharmacy that you're looking out for catch-up for HPV, all the childhood vaccines, and just a reminder that the MMR vaccine is funded at any age by New South Wales Health. Well, anyone born 1966 or over, so well outside the adolescent age group, and particularly important for people perhaps born overseas who may be visiting your practice to check that they've had 2 doses of MMR vaccine. So just a quick rundown of how the school program works. It's run out of each public health unit or local health district, and we employ teams of authorised nurse immunisers. In my district, Southeast Sydney, there's over 90 high schools, and we schedule at least 2 visits to each school every year. Parental consent is essential for us to vaccinate the child. In the past couple of years, that's been available online through the Service New South Wales app, but we still do have the old paper consents available if the family has trouble accessing the Service New South Wales, and also people who are not Medicare eligible have to use a paper consent. Now, post-pandemic, there's a lot more absenteeism from schools. So we are missing out students on our regular vaccine days, but we will continue to offer catch-up. As long as the parents consented, we'll offer it even in year 8 and year 9, or for the year 10 students, we'll continue to offer it when we're at school in year 11 and 12. So we make every effort to offer vaccine to all consented students. And the system we have now transmits vaccination records directly to the Australian Immunisation Register, so parents can readily see and you can readily see whether or not the child's been vaccinated. So just a quick poll, excuse me. What do you think is the latest, this is 2023, coverage for HPV and DTPA vaccines in New South Wales by the time they turn 15? Just a reminder, of course, the HPV vaccine is now just a 1-dose course, so any adolescent who's received 1 dose by the age of 15 is considered fully vaccinated. Well, you're a little pessimistic. In fact, 86% of young people have received both those vaccines by the time they're 15 years of age. And by age 18, for the meningococcal ACWI vaccine that's due, we offer in year 10, how do you think we go with coverage for adolescents for meningococcal ACWI? Yes, you're a little over optimistic there. And one of the, as I said, attendance at school is a real factor in how much uptake we can get with these vaccines. And by the time that children are in year 10, they're not as reliable in attending as they were in year 7. So yeah, we get about 75% of adolescents receiving those vaccines. And unfortunately, again, linked to attendance, we're getting quite low uptake amongst Aboriginal adolescents. Only about 62% by the time they reach 18 have received that vaccine. So as you'd be aware, that's really crucial that we make work together to increase coverage amongst Aboriginal adolescents of the meningococcal ACY vaccine. Yeah, so how can we work together to better protect young people using these wonderful funded vaccines? So I'm just going to talk about HPV vaccine, Gardasil, for a little bit. And we've done a bit of research in our public health unit about parental attitudes to this and what the barriers might be. So basically now we can look at Gardasil as one-shot cancer prevention. So it causes almost all cervical cancer, more than 90% of anal cancer, 2/3 of vulvar cancers, and 1/3 of oropharyngeal cancers. And that's not the full list of cancers that HPV has a role in. And then there's other serious conditions like juvenile onset recurrent papillomatosis that caused by HPV. So it's to blame for a lot of illness and cancer, and we have a national goal that 90% of girls and boys are vaccinated with HPV by 15 years of age by 2030. So in New South Wales, we're doing quite well. We're at 86%, but we can't be complacent about that because we're still battling post-COVID attendance and vaccine hesitancy. So our numbers have been declining the past couple of years. So to maximise the impact of Gardasil, it should be given prior to exposure to HPV, and it's registered from 9 years of age. And we now have good data that one dose provides effective long-term prevention. So some of the data out of an evaluation that NCS did a few years ago about the first 10 years of program, they compared observed a couple of outcomes in the pre-vaccination cohorts and the post-vaccination cohorts. So the high-grade cervical abnormalities, that's CIN 2 and 3, are decreased by almost half in women under 20 years of age, so who'd been offered vaccine, and by 20% in women who may have had vaccine in the early stages of the program. And I'll leave you to look at these graphs in a little more detail later, but it's looking at, for example, looking at people who are aged 20 to 24, so pre-vaccine program, they had about 20 high-grade abnormalities per 1,000 women screened. And after the program was introduced, so it's a different cohort of women each as the time passes. So as each new cohort of under 20-year-olds or 20 to 24-year-olds is exposed to the vaccine, the rates of high-grade CIN decrease. And then similarly, anogenital warts. So this is an early win with vaccination as more and more cohorts of young people were exposed to the vaccine. We had some very dramatic drops in anogenital wart presentations to hospital. So the evidence is there. It's an effective vaccine and it's safe. But when we interviewed parents, they came up with a number of reasons why they were hesitant about their children receiving the vaccine. And I'm not sure if you've heard this theory before, but in combating things like vaccine hesitancy, it's recommended that we counsel our patients using a truth sandwich. So it's placing information that's all information is truthful, but positive information around the negative message that the patient might hear. so that the last thing that they hear is a positive message about the vaccine. So this is a quote from a parent we interviewed. And she said, I mean, it'd be great to hear of someone who's actually in their 30s who's had it done, but I don't know if there is. I don't know how long the injection's been out. I don't know how long it's been out given to the public, but not school children. So I hope you can now say that Gardasil's been given to school children in Australia since 2007. So that's for 18 years. And some of the women or the girls that were first vaccinated are in their mid-30s now. So you can empathize and say, well, it's not as familiar as tetanus and whooping cough vaccines, and you probably didn't have it when you were young. But around the world, over 50 million people have had the vaccine, and here in Australia, more than 8 in 10 teens get the Gardasil vaccine every year. So that's our truth sandwich for people who might be worried that it's a new vaccine. Another comment that was made to us is it causes infertility. Then you read things that people are saying, don't do it, it can make the men sterile. So what are the facts here? So there have now been hundreds of thousands of people who've had HPV vaccines and have been studied, and there's no evidence that HPV causes infertility. So that's comparing cohorts of vaccinated and unvaccinated people in their hundreds of thousands. But you can emphasize with that, and you can say that you hear rumors about negative health impacts from Gardasil, but put a fact back to the parent. But there's actually some studies showing HPV vaccine can improve male fertility, as the HPV infection can also harm sperm. And the final one, and a common one, is that parents believe that getting HPV vaccine encourages sexual activity. So this is another quote we had verbatim from a parent. If you only have sex with 1 or 2, the problem won't be there. So to counter that, you could say, even if your child has only 1 sexual partner in their lifetime, their partner could already have HPV infection. So put your child at risk if they're not vaccinated. And we do have solid research that there's no difference in the age of first sex between teenagers who get the vaccine and those who don't. And you can finish by saying getting the vaccine now gives your child the best protection against a range of cancers, no matter what decisions they make in the future. So that's just a few examples. So in summary, to support Gardasil update, it's really helpful if you initiate the conversation with parents and young teens about the school program, and they'll have this opportunity at school and how to consent. If they raise myths or hesitancy, try to reassure them on effectiveness and safety. And particularly as they're getting older, check on the air, and if they don't have an HPV dose recorded, offer a free catch-up, and that's all the way up to age 25. I'll just also touch briefly on the other vaccines we offer. So we offer DTPA, and it's really important to boost protection against diphtheria, tetanus, and pertussis through the adolescent years. And by vaccinating at around 12 or 13, it's also giving good protection against diphtheria and tetanus. Once they get into older adolescents and they start to travel to parts of the world where diphtheria is still being active, and of course a tetanus-prone wound can happen at any time. I just wanted to touch briefly on this graph, and it's comparing 2 years of whooping cough pandemics, 2024 in the blue, and 2015, which was actually our last big whooping cough epidemic in 2015. So you can see here in both periods, the vaccine regimen in childhood covered and controlled the outbreak well, and there's very similar numbers of cases or rates of cases through the early childhood years. But particularly in 2024, once children started to have more and more years between their booster at 4 years of age, and their next one that's due at 12, we really saw a big increase in whooping cough among older primary school children and the first year of high school. But then once we were able to give that booster sometime in when they were 12 or 13, the rates really dropped off. So really important timing for that whooping cough booster we don't want to give it any more frequently at the moment, but there's certainly a lot of loss of protection between 4 and 12 years of age. So supporting DTP uptake, once again, have the chat with parents of young teens that will be offered to the students in year 7. If a young person presents with a tetanus-prone wound and they're 12 or over, check to see if they've had their DTPA, and if not, use that rather than DT as part of the response to a tetanus-prone wound, and that is funded once they turn 12. And finally, meningococcal ACWY. So there's 2 peak periods in life for meningococcal carriage and for invasive meningococcal disease. The first is in early childhood, the first couple of years of life, and the second is in young adulthood. So that's why our schedule gives meningococcal ACWY at 12 months of age, and then again at 15 years of age to provide optimal protection both to the individual and also to carriage and community transmission during the periods when children and young people are at the highest risk of carriage and disease. And we get population-wide benefits by vaccinating, particularly, I think, our 15-year-olds. So this is New South Wales data on invasive meningococcal ACWY disease. We don't have any A in New South Wales, so it's CWY, from 2010 to 2014. So by 2010, the meningococcal C program was controlling well, the meningococcal C, which is in blue. And we had, these are case counts, so very low numbers of non-B meningococcal disease in New South Wales. But then from about 2014, 2015, we started to see the emergence of meningococcal W, which is in orange in these graphs. And this was an international emergence of a new hypervirulent clone. So we saw big increases in our case counts in New South Wales. So in 2017, we introduced the meningococcal ACWY program in New South Wales. And then in 2018, the meningococcal C vaccine in infancy was changed to meningococcal ACWY. And the combination of using vaccinating those 2 cohorts has effectively almost eliminated meningococcal W disease in New South Wales. There's still a little bit of Y. So I think that's a really nice illustration of the effectiveness of not only protecting, direct protection to babies and young people, but also the whole population. I have to hurry now. I'm going to run out of question time. So similarly for meningococcal vaccination, so once you see mid-teens, 15-year-olds, remind them that's coming up and remind the parents that they have to consent. But if you see them when they're a bit older, proactively check the Australian Immunisation Register, and up to 19 they can get free catch-up. And also discuss the added benefit of Bexsero, so meningococcal B vaccine, which is of course the main cause of invasive meningococcal disease in Australia now, particularly if they're intending to go to college or live in some other high-risk setting. So in summary, the things we're looking at for adolescents, we've talked about the school program. The meningococcal B vaccine is a 2-dose course unless they've previously been vaccinated, in which case they could just have a booster. That would be given around 15 years. It's a private purchase and could be recommended, particularly if they're going to boarding school or college. And influenza annual, we've talked about the eligibility there. Another one to mention is varicella, so the young adolescents, the same as for children. A second unfunded dose is recommended for optimal immunity. And then, of course, any missing childhood vaccines are also free catch-up up to 19 years of age. So I think the Australian Immunisation Handbook's really handy to be able to check all these things. It's very clear there what the recommendations are for different age groups and what's funded and what's not funded. And the final thing I was asked to speak about tonight, sorry, it's a bit of a shift in topic, is when vaccines are privately purchased and transported from the pharmacy to the general practice. Just a few reminders, both for GPs and pharmacists, to talk with patients. So as you're all aware, vaccines are delicate biological substances. They must be kept between 2 and 8 degrees and also protect from light in their original packaging. So it's a bit like looking after fish when you buy it from the fish market. You don't stick it in the car and go and do more shopping and leave your car in the sun. Really important to make the vaccines effective. Some tips might be to pick up from the pharmacy on the way to your next appointment. If it's going to be kept at home, is there a fridge thermometer? Because also freezing vaccines is just as bad or sometimes worse than exposing them to heat. Just a small insulated lunch bag is a good way to transport it between pharmacy and general practice, but also a reminder if there's an ice brick involved, don't put the vaccine directly on top of that. It needs a bit of insulation in between because the vaccine could freeze on sitting directly on an ice brick. So that's, I think, my final slide. So I will leave it there and thank you for your attention and happy to take some questions.
Thanks so much, Vicky. That was excellent to update everybody on what we're doing with adolescent vaccines and remind our primary care providers of the role that they can play in helping to administer the adolescent vaccines. We have a few questions. First one, why is the HPV vaccine given at a younger age? Is it more about sexual debut or a better uptake in younger years?
The main thing is to have it before you're exposed to the virus. So that may be related to sexual debut. There's other ways to be exposed to HPV virus, but it's the other aspect of giving it young, and one of the reasons it's registered from 9 years of age is that the immune response is actually optimal in young teenage years. So by giving it in year 7, we're getting an optimal immune response, and also largely before the child's been exposed to the virus.
Great, thanks. One about Nimerex, recently removed from the NIP for the Year 10 ACWY. Any particular reason? And if a Year 10 student comes into the medical centre, can they have Nimerex or do we have to give Menquadfy?
No, yeah, it's fine to give Nimerex. I think this was perhaps some kind of a contract financial thing. There's the vaccines are considered equivalent, and very happy for you to use Nimerex rather than Menquadfy for catch-up for adolescents.
Great. Maybe more of a call out, but Narelle is saying we're still seeing healthcare workers who've been given ADT instead of DTPA, apparently due to doctors' bags being stocked with ADT. And yeah, we do hear this a lot as well. And, you know, we do try our best to communicate this to GPs. Is there any more comment you'd like to provide there, Vicky?
Yeah, well, of course, for the healthcare workers, it's a state-funded vaccine, so you don't have those in your fridge, so it is a little bit awkward. But if the healthcare worker is able to get along to staff health, then it would be able to be given free there. or they may be willing to, as Tran said, to pay to get the full protection, and that can then go on to their staff health record, and then they won't need a booster for another 10 years. So that's definitely an option. If you give them Boostrix that they pay for themselves, it'll go on to air, and then they won't have to worry about getting another vaccine at staff health.
Great. And on Bexsero immunisation, if a patient has had a full schedule in the early childhood, is a booster in adolescents recommended?
Yeah, for optimal protection, then one more dose is recommended, and that can be timed according to their risks. If any time from about 15 on, I think would be probably a good time to do that.
Great. And one that Mimi's started to answer with some text, but I thought I'll get your commentary on it as well. And older international university students who are under 26 frequently request 3 doses of Gardasil 9. Who recommends 2 doses? Does the 1 dose data apply internationally?
Yes. When you said who, yes, WHO
Sorry.
recommends. Yeah, look, our Australian recommendations, ATAGI, is that 1 dose is fine up to 26 years of age. So I would use, similarly as Tran said, that's a very clear recommendation in the handbook, and that would be the information I'd be giving, and we wouldn't be able to fund any additional doses than the one. And that's it, if they're eligible for a free catch-up in Australia.
Great. Excellent. Well, thank you so much, Vicky, for your time. That was another great update and a timely reminder as well for cold chain at the end. I have a little bit of shameless promotion for the PHN. So let me just share my screen. So I just wanted to quickly remind everybody that we produce cold chain vaccination fridge temperature logbooks.
Kira, we're not yet seeing your screen.
Oh, sorry. Thank you. Share. How's that? Are you seeing it now?
Yes, that's fine.
Great. So yeah, just wanted to remind everyone that we produce annual fridge temperature logbooks. They've got 12 pages of the min-max temp charts, a reminder to self-audit, and some useful information and cold chain breach stickers in case you need them. And you can order them via email, immunisation@cesphen.com.au. Secondly, a reminder to do your vaccine storage self-audit annually. This includes the annual fridge service as part of your self-audit. And it's always a great idea to refresh your cold chain skills by completing the HETI online form. And important reminder to include all new staff with this training as part of their induction. And just finally, as we're all aware, falling vaccination rates in children, they've been falling since 2020. So if we can all do our bit to ensure vaccine uptake. For us at the PHN, we keep an eye on the coverage and then do what we can to support our immunisation providers in following up overdue children. So this includes sending out overdue childhood reports. You can register to receive these if you're not already. There's a form on our website and there's a link there. And then your report comes in a platform similar to this. You can see your 2024 progress and then have the overdue children report. We also can pull out the priority children, so the ones you might want to start with first, the Indigenous children, if you wanted a smaller, starting spot to focus on, and then you can get a printable PDF report of all overdue children for your practice, which will look something like this. So each coloured box is a different child, and every antigen that they're overdue for. We provide a QI template to log the actions of your quality improvement activity, and our team is on hand to encourage team viewer sessions, and you can always call as well if you require further support. And here's an example of the QIA workbook. It's got actionable outcomes to follow up with children that are overdue, if that's maybe due to data quality or inactive patients, transient populations, or duplicate records. It supports you through all that. And finally, our website is our one-stop shop for everything immunisation related. We also have our immunisation weekly update within the Sydney Health Weekly. And if you need further support, visit our website, or you can send us an email at immunisation@cesphen.com.au. And I think that is it. So thank you everybody for attending tonight. Stop sharing. All right, is that stop sharing?
Yes, that's fine.
Thanks. Thank you all for attending tonight. We hope you learnt something new tonight. And thank you to our speakers, Vicky, Tran, for your presentations this evening as well. A reminder that an online survey will pop up in your browser at the end of this session, and please fill it out, as it allows us to have informed information about future planning of these CPD sessions. Thank you everyone, and have a good night.